So I would like to welcome everyone to this week NeuroTalks. Today we have a very special guest. We have Dr. Luisa Biscoito, who is a very experienced interventional neuroradiologist from Portugal, from Hospital de Santa Maria. She was also a former president of CILAN last year. And so welcome and thank you so much for joining NeuroTalks today, Dr. Luisa.
Okay, thank you, Tiago. First of all, I want to thank you to the invitation to present this talk, and congratulate you for this event to share neuroradiology knowledge, and it was really very interesting to make this. I'm sorry. Okay. Thank you to everybody to be connected with us, and I hope everybody is okay during this strange time that we are living. Yeah. And this next minute we are going to speak about this subject, the dural cavernous sinus. I will make a general part, and then I will speak a little bit about the approach, the superior ophthalmic vein approach. It's nothing is new. It's done by the most experienced neurointerventional in the world, and is described since a long time ago, but I had this case with a very good iconography. I did some photos that I would like to share with you, and maybe it will help somebody. So,
thank you.
Okay, I will just, okay, here. We can put here. Okay, so the dural fistula, they are a normal vascular shunt between arteries and veins within the leaflets of the dura mater. The etiology remains unknown, but they are acquired lesions triggered by intrinsic and extrinsic factors. It's more frequent in women and in older patients. It's not frequent disease, and it represents 10 to 15% of intracranial arteriovenous malformations. The location, most of them are located on the transverse and sigmoid sinus and in the cavernous sinus, representing around 75% of all the dural fistula. The rest of the locations are really rare. The clinical feature, the clinic depends on the type of the venous drainage. The fistula, we know that it is a dynamic process. It's evolving on time. And we can have low or mild symptoms till severe symptoms. The most frequent are red eye, the chemosis, the exophthalmos more or less pulsatile, the ophthalmoparesis more on the sixth nerve, and the consequence of diplopia, the brute, the retroorbital headaches, the visual impairment, and of course, if they have cortical venous drainage, they can have neurological symptoms like seizures or more aggressive hemorrhage or edema. Diagnostic imaging, when should we do? Of course, in cases with classical symptoms, we are going to study and do image to see if it's really a dural fistula, but also in the refractory red eye. This is very important because these patients sometimes go from an ophthalmologist to another ophthalmologist and from symptoms that look like allergic or conjunctivitis, and finally they are it's a dural fistula, so we have to be aware of this. What do we do? We do or CT or MR. It depends on the availability of the equipment, the experience of the group, and the objective is the correct and fast diagnostic, of course, to lead to the planning of the treatment. The digital angiography we can do first for confirm the diagnosis and study the angioarchitecture of the fistula, and then proceed to the treatment in another session, or do at the same time. It depends on the way of people work. But do image when we see this. What we see on the orbit some signs: asymmetry of dural sinus density, dilated vein, dilated cavernous sinus, hypertrophy of the external muscles of the orbit, venous thrombosis, proptosis, and if there is cortical venous drainage, dilated cortical veins or edema or hemorrhage. In CT, or we see here the proptosis, and we see the dilated external muscles of the orbit. In the coronal, it's very good to see the dilatation of the muscles and dilatation of the vein. Here we see dilatation of the vein, and the dilatation also on the cavernous sinus here. So it are all signs that we can see. The CTA nowadays, it's a very good quality. So we can do the VRT and see all this dilated vein and all the veins here, the supraorbital vein, the angular vein, and the anastomosis to the other side by the frontal, this frontal vein, just beneath the skin. And now we have the 4D CTA that we can see like an angiography all the times to just the end of the venous time. On the MR, on the T2 sequence, we see the cavernous sinus, and the normal cavernous sinus is on the intermediate sign. It's not black. The black is the flow void of the ICA, like the vertebral artery, and on the right side we see this normal black dot. So it's an arterialized cavernous sinus. So it means that there is an increase of the flow in the cavernous sinus, the pressure in the cavernous sinus, like an artery is arterialized. Here, the dilatation of the muscles and the proptosis. In the coronal, it's very good to see, as I said, in the CT, also in the MR, dilatation of the muscles, and here the vein. On the MRA, on the source image reconstructed by MIP, we see the arterialized cavernous sinus, so we should not see bright signal on the veins in the TOF sequence for the artery. So if we see this, it means that this has increased speed in the cavernous sinus. So, and here in this case, this is the reconstruction. So we see here the cavernous sinus, that is this, and then we see also the lateral sinus. It means that this dural fistula is draining also to the deep venous system, and then to the lateral straight sinus, and finally lateral sinus. And we confirm this here on the angiography. We see this is a fistula, dural fistula, that drains to cortical, the cortical veins, and also to the deep venous, and then straight sinus, and then to the lateral sinus. So the symptoms and signs are usually benign. but because the cavernous sinus have multiple venous drainage, and the symptoms and signs depend mainly from the direction on the venous side. So here, this is the example. The main efferences are the superior ophthalmic vein, the superficial Sylvian veins, the basal veins, the petrosal veins, the prepontic. So all these veins are main afferents. Here we have a fistula, of course, and the main efferents are the inferior petrosal signs, the superior petrosal signs, the foramen oval veins, and then drain to pterygoid venous plexus, the contralateral cavernous sinus, and clival venous channel. So a lot of venous channels are connected with cavernous sinus. From the arterial part, the arterial efferences can come from the internal carotid artery by the dural branches from cavernous segment. We see here, and the inferior lateral trunk that is going to anastomosis with the branches from the external carotid artery that have also afferences from distal branches from IMA and from middle meningeal artery, accessory meningeal artery, and extending pharyngeal artery. From the classification point of view, the Barrow classification is a classification done based on the afferents of the arteries. So we have the type 1A, that is the direct fistula that we are not going to speak today. And then the other three, the type B, C, or D, depending on the afferences. So the B, it's only afferences by the ICA, the C only from the external carotid artery, and finally the D is from both, from ICA and external carotid artery. And these are the more frequent that we see on the clinic. If we adapt the Merlin-Cognard classification, the cavernous sinus fistula are only from type 1 and type 2. They cannot be on type 3, 4, or 5 because they drain first to a dural sinus. So we exclude these three because these are those that drain to cortical veins. So these are type 1, drain to the cavernous sinus in this case, and then to IPS, and or draining with reflux to the other cavernous sinus or to cortical veins, or to both. Regarding treatment, of course, everything should be as simple as it can be, but not simpler. What is the pathogenesis of the dural AVF? They are based on events that happen related to post-infectious with hormonal traumatic or thrombophlebitis, and are based on the venous thrombosis and shunts that open and shunts that hypertrophy. And if we have venous thrombosis, we have increase of venous hyperpressure that will induce the release of endothelial growth factor and hypoxic induced factor that will induce more angiogenesis and vascular remodeling that will tend to do more neovascularization, inflammation, inducing more factors to angiogenesis, more increase of vessel thickness with high turbulent flow that will lead to more venous thrombosis. So this is a circle and vicious circle, and so with the treatment we want to cut this circle. We know that venous thrombosis events are related with development of dural fistula. We know that ophthalmic symptoms of cavernous sinus fistula occurs with thrombosis and the occlusion of main drainage of the fistula. With treatment, so we are going to promote an occlusion of the main drainage of the fistula and the fistula itself, and will induce regression of symptoms when establishing the normal gradient of pressure. So finally, what we want to cut the high gradient of pressure and normalize the gradient of pressures. Not to become with a normal venous anatomy, but to cut with the high gradient of pressures. Finally, we want to do the same thing that sometimes provokes the symptom, that is the thrombosis. So we are going to induce a thrombosis, but it's a controlled occlusion and controlled thrombosis. When should we treat? Of course, when we don't want to have risks on the ophthalmic and neurologic. So when we have ophthalmic risk without cortical venous, so those without cortical venous drainage, we are going to treat the ophthalmic symptoms. When we have fistula that drain also to cortical venous drainage, apart the drainage to the ophthalmic vein, we want to treat because of ophthalmic symptoms and to decrease or to cut off with the neurological risk. And the best way is to reach the foot of the vein. So how are you going to reach this? By endovascular, that is what we are talking about, by the venous approach or arterial approach. Nowadays we use more the venous approach, either from these different ways or different routes, depending on the angioarchitecture of the fistula. The options. We know that some of these patients, some with this dural fistula, have spontaneous fistula closure. So sometimes they close spontaneously. Sometimes they have so slow flow that they can be treated with cervical compression of carotid artery. But to do that, it's good to exclude first carotid atherosclerosis stenosis and then say to the patient to compress with the contralateral hand. But it's not all the patients that accept to do this continuous till the occlusion of the fistula. From the arterial route, we have to pay attention to the use of liquid agents because of the anastomosis of the eye with the internal carotid artery and the vertebral artery with the external carotid artery and the vascularization of the cranial nerves. And we can use also the particles. From the venous route is the most used. The IPS is the best approach. Even if it's not seen, it can be catheterized in some cases. The VOS or fascial vein can be used if IPS failed, and there are another routes less frequent like superior petrosal signs of pterygoid plexus or cortical vein. So, the treatment planning, what we detect is the type of venous drainage. And we have to make some key questions. Does the fistula drain to a catheterizable venous access? Are the IPS patent? Is the IPS connect to the compartment of fistula drainage? Because sometimes we can go on the IPS and we cannot pass to the compartment of the dural fistula drainage. Does the fistula drain to the VOS? Is the VOS catheterized? Is there a fascial vein? Is the fistula uni or bilateral? Where does it is draining? And does the fistula drain to cortical veins? Because this puts the treatment more urgent. We use different materials, everybody knows, from particles, glue, coils, and this more recent liquid embolic agents that precipitate and no polymerize like the glue. And by all these materials, what we want to do is to reach the foot of the vein. So we are going to try first from the IPS, that is the best and easier. If not, we can, in this case, going to see from the superior ophthalmic vein. Some examples. This is the typical good example. That is a woman with the classical symptoms of dural fistula. She has a fistula from with afferents from the eye and both external carotid artery. You can see all this network draining to the left cavernous sinus. And it was easy. We went by the IPS, and then we occlude with the coils, and we excluded the fistula, and the fistula was excluded from with the coils by the IPS. The IPS was permeable, and was so the ideal treatment. But we have in this case, for instance, another case, a woman after intense cold, she developed hyperemia, ptosis, and brutal diplopia, and she had a fistula. You see here from the external carotid artery, we see here the venous part, the cavernous sinus, but is draining to the superior ophthalmic vein, but we don't see the IPS. We don't see the IPS, but it doesn't mean that we cannot catheterize. We can catheterize, sometimes because maybe it's the fresh clot inside of the IPS. Of course, if the anatomy of the IPS is not favorable, we cannot reach the cavernous sinus, but we should try. We should try, because sometimes even if you don't see it, is there, and we can catheterize like here, and we reach the cavernous sinus, and then we put coils and we exclude the fistula. In some cases, for instance, in this case, another woman, spontaneous and progressive hyperemia, she had a fistula with low flow that was partially already thrombosed, and we went by the IPS, and we saw that all this cavernous sinus was healed, was partial thrombosed, and we reached the foot of the vein that actually was the foot of the ophthalmic vein, and we could put some glue, because we see the point of the fistula was here. We see a selective injection on the foot of the vein, and we inject glue, and we excluded the fistula. We control both sides, and it was excluded. Arterial indirect approach, we can use it. This is an old lady with a high chemosis, intense chemosis. She had a fistula. It's an old case. She has a fistula that was already partial thrombosed of the ophthalmic vein, and it was no access for IPS, or at least no IPS visible. And what we've done, we did embolic, and we embolized the internal maxillary artery with particles. And why with particles? To decrease the flow in the ophthalmic vein and favorize thrombosis and occlusion, because the nasal fossa is a venous reservoir. We have the orbit that drain to the ophthalmic vein, and the nasal fossa drained also to the ophthalmic vein. So if we embolize the mucosa of the fascia, the nasal fossa, we are going to decrease the flow in the ophthalmic vein. We are going to induce more slow flow and more thrombosis. So we are going to help a little bit to continue the process that was already developing on the natural nature. And so it occlude the fistula and regress the symptoms. There are other cases that we have a fistula that was a congenital fistula only to draining to a huge orbital ophthalmic vein, and to say that we can use also the fascial vein and go retrogradely to the point of the fistula and occluding the fistula. So we have to reach the foot of the vein, no matter from where. It's the best way to to achieve. They have this article from Professor Biondi. In this, our patient, she's a 66-year-old lady that has proptosis and red eye bruit with a pulsatile nodule in the internal side of the upper lid. We did the diagnosis by CT and CT angio, and we see maybe the nodule is this curve of the ophthalmic vein, and we see the dilatation of the cavernous sinus. The angiogram confirmed the fistula draining to the right cavernous sinus with afferents from both sides, from external and internal and right and left, and draining to the right cavernous sinus. On the vasal CT, we see that all these tiny vessels from the external carotid artery are going to the wall of the cavernous sinus. So it's a disease of the dura mater, no doubt. And here we see the angiogram and the filling of the cavernous sinus, and then reflexing to the ophthalmic vein, and the others to the other side also from the frontal small vein that is crossed on the face. We try really to reach this point of the fistula by the right side, because we did an injection on the carotid and on the venous at the same time. When we see this, we saw actually that the carotid drained preferential to the ophthalmic vein, but when we inject by the venous, we see that she had patterned the IPS. We tried from the right, we tried on the left, and we could not pass to the septated and compartment of the fistula. And we see that here there is a very irregular interface in between the part of the fistula and the part of the cavernous side that is very irregular and maybe partial thrombosis. So I tried with several guide wires, and in one time the guide wire passed, but the microcatheter did not follow, and actually we try and then we quit, and we decided that we're going to the superior ophthalmic vein approach. It was first described since long time. There are several descriptions in the literature, several papers, some with a few cases, some case reports, some more larger series. We have from Brazil, from our friend that it's not anymore here, and we have here the review of the technique of the superior ophthalmic vein approach. We did on the general anesthesia with a sterile field, of course, as we do all the procedure and we put a femoral sheet to put a diagnostic catheter in carotid artery, in this case on the right carotid artery, and it is a multidisciplinary procedure. We have the neurointerventionalist team, it's me, my colleague Gonzalo, my fellow Manuel, and the colleagues from the plastic team, Dr. and the senior, and Inês, the fellow. We have the anesthetist, of course, because it's under general anesthesia. We have nurses and radiology technicians. It's made in the angio suite, and of course the surgeon took the surgery tools. We spoke with them, we explained exactly what we wanted to do to puncture the vein and to follow till the cavernous sinus and to occlude the cavernous sinus. So in the supine position, we see that nodule that is the vein, and I want to expose this part of the vein. The dissection of they cut and then dissect the incision in the medial upper eyelid crease, and then the dissection through the orbicularis oculi muscle. They open the septum and they expose the recto-septal-medial fat pad. And then we see the vein here, and it's exposed, the suspension of the skin, and slowly dissecting the plans around to expose the vein. Here we see the arterialized vein. This is the fat, and the vein exposed, that curve, that big curve that ophthalmic vein does when the junction of with the angular nearby the angular vein. Here it is exposed. We see here very completely arterialized. So this part here of the vein. And we passed the suture, the silk suture loop in the vein. We did this to allow manipulation and to make sure that if something happened, the rupture of the vein, we could close the vein and to control the hemorrhage. And then I punctured, this is my left hand, I punctured with Abocat 18 the vein. You see here the puncture. Of course, with an Abocat, we took out the mandrel. Here is the site of the puncture. We control the stabilize. It's important to stabilize the needle in the ophthalmic vein, and then we connected an extension to plastic tube. Here, the Abocat, we connect the tube, and then we fix the tube, and we worked like the other procedures nearby the femoral approach, and we did not touch anymore this part of the field. We had a roadmap. This is at the beginning, before stabilizing everything, to see with the guide wire to see if we are in place, and then after stabilizing all the device, we worked and immobilized with coils like we were working on the femoral approach. And we packed the cavernous sinus with 7 coils in this case, and exclude completely the fistula. At the end, we see that it was completely stabilized. The Abocat did not make any movement, and then we are going to disconnect. We disconnect the Abocat from the hub, and you see that there is no more flow, because the fistula is occluded. At the beginning it was arterialized when we punctured, and now there is not any more flow. To take off, I was trying to take off the Abocat. You see, it was fixed. It was very, very well stabilized in the vein, and actually, because it's plastic, it was fixed to the wall of the vein. Of course, I did try to twist a little bit. I did not want to destroy the vein, so we put a little bit of saline serum to hydrate, because maybe it was without humidity, and then with a little bit help here, it came out very, very well without any problem. And you see that there is no more bleeding, and just a little bit of compression, and nothing more. And here we see after that the point of where we puncture, and the integrated vein, we did not destroy the vein, and finally the scar and the suture, and this is after 3 days, and this is after 3 months, that we don't see even anymore where was the scar. So the SOV access is a safe and effective technique that requires a multidisciplinary team. The indications is where, of course, when the other routes to access the fistula failed. the ophthalmic vein, of course, should be accessible. Well, the disadvantage, it need to open the skin, so it's the reason why it's not the first option, and should not be the first option. Complications are not frequent, but they can happen, so we have to be aware of damage of nerves or vessel rupture with hemorrhage. It's the reason why we put the suture silk to try to control if there was a problem. And thank you, everybody.
Well, thank you, Dr. Luisa Biscoito. Thank you for the beautiful images that you brought today, and for the excellent explanation of the basics and of what you've done specifically in this case. I have two questions for you. The first one is, where do you start coiling the cavernous sinus? Because usually, if you go from the inferior aspect of the superior of the cavernous sinus, you start coiling at the root of the ophthalmic vein. And I think here you probably have done on the other way around, from the posterior aspect of the cavernous sinus into the ophthalmic vein.
Yes, thank you for the question, Tiago. Yeah, we try to pack all the cavernous sinus to don't make septations, so we go from distal to, in this case, to proximal. Sometimes even the microcatheter make a turn, but we want to get really inside the cavernous sinus, because the worst thing, of course, is to turn dural fistula from, for instance, a VOS drainage to a cortical drainage, and this is it's the more problematic, or draining on the posterior part to other that then it's not reachable. So we have to pay attention to that.
Yeah, and the other question is, when you puncture the vein in the beginning of the procedure, are you closing the suture to avoid the vein being so tumor factive, or you just puncture it very gently, and so you don't, do you close those sutures or not before puncture?
Okay, no, we didn't. Actually, we did pass the silk suture only to, just in case. Just in case something happened, and then we puncture very caution. What we have to pay attention is, because it was very dilated, the vein, so we have to be sure in which direction we are punctured, to not puncture in the direction that it's going to facial vein. And we should puncture in the direction, in the loop, but in the direction that is going to cavernous sinus. Yeah. Otherwise, then we have to turn the avocat, and it's more difficult.
Yeah, we have some questions from our colleagues. One is, do you always have the plastic surgeon? I think, well, it's not a plastic, is a plastic surgeon, ophthalmologist, or both?
No, they were plastic surgeons. Okay. Yeah, I think we had experience before with other colleagues. Well, it depends, I think, on the hospital to hospital and countries to countries, and depends on the ophthalmology, what they do in our hospital. If they are more for cornea, for retina, and or if there are ophthalmic surgeons that are more for the orbit. In our hospital, probably because of this, the more that they do more upper lids are the plastic surgeons. The reason why I went with them, and I explained to them, and actually it was very good, because they are very used to make surgery in this part of the eye, and the ophthalmologists are more for inside the orbit. So it was very good. It was they understood very well what we wanted, and because they are very used to do this kind of approach, because I think it's like a blepharotomy when they do the surgery to the upper lid.
Yeah. Some other colleagues are asking why not the direct puncture of the ophthalmic vein by ultrasound or not? Why not the direct puncture, and why is important to expose the ophthalmic vein and then puncture the ophthalmic vein?
Yes, it can be an option to puncture directly, but I think it's more risky because we don't control. It's a fragile, sometimes it's a fragile vein, and when we puncture, even if it is an abocat, it goes in front of the vein sometimes because it doesn't have too much place to make pressure and the make counter pressure when you puncture. So we can risk to damage the vein and to promote an intraorbital hematoma. So
Yeah.
probably
Well,
it works, but from my point of view, we feel more safe. Of course, we have to open. There is a scar. They open the skin, but it's better to control ourselves looking for than puncture on the blind way.
yeah. Well, and the hemorrhage of an arterialized vein can be very difficult to control, and you can see the globe just coming out of the orbit, and is very, very scary.
Yeah, then you need emergency surgery to drain the hematoma. Of course, there are techniques. They puncture retrogradely the vein in the orbit. If there are different several techniques, and even the direct puncture of cavernous sinus. But
a colleague of us is asking the system of the tube that you connect to the avocat. So it's just a normal tube, high pressure tube, and then you use it as a guiding catheter, basically.
Yeah, it is
a normal.
It's a regular tube, a prolongation tube for saline serum. It's a normal one. We connect to the avocat, and then in the other extremity, we put a lower lock, like if it was on the catheter guide. Actually, it's like creating a catheter guide. And then inside of this tube, we insert the microcatheter.
Yeah. Well, we have some compliments as well, and for your presentation, and well, there's a last question, I think, asking about which materials are using preferably in this situation. Well, of course, it's coils. Would you use any other material, non-adhesive or glue?
Yeah, well, in that the other fistula that I showed, that it was a very, very tiny point of the fistula. We decided, you remember, to inject the glue because it was so small that that part that drop a little bit of glue and it closed the fistula. In this bigger cavernous sinus, we are very used to coils. Of course, we can use not glue, I don't know, but we, of course, maybe it's possible, but it's so easy to use coils, and it can mix with onyx or squid. It can be done also. That are different approach, but to use this several or coils and liquid in agents like squid or onyx can be done. The important is to control and to not extravasate from the cavernous sinus. It's not our objective. It's not inject everywhere. So control the injection or control the coils, and to not pack completely to increase the pressure in cavernous sinus, but we pack till the fistula is shut down. And to the microcatheter is a regular catheter. I think it was, I don't know, echelon 10 and a normal regular micro guide wire, and well, nothing special. And the apocat, it was a regular 18 apocat, the smallest. There is a longer one and the smaller one, which is the smaller one. And actually, to prolong the prolongation to work like a femoral approach, it's very good, because if we don't put that tube, that plastic tube, to create like a catheter guide, there are two disadvantages. One is we manipulate the catheter, the abocat, and it's unstable and it can come out. So like this, we are not touching anymore. And the other thing is that we work in security and not so close to the tube of the radiation tubes.
Yeah. Regarding anticoagulation, are you doing any specific schema for the situation, or just a regular anticoagulation schema for fistulas?
Actually, I think in this case we did not anticoagulate.
Okay.
We use, when we do bifemoral, the other bifemoral approach, we always do a bolus of heparin between 3,000 and 5,000 at the beginning, and then the regular 1,000 each hour if it takes too long. So the normal anticoagulation, and sometimes even keep the patient with some anticoagulation for 2 or 3 days. It depends on the result after, because sometimes you know that when we occlude the fistula, we can increase the symptoms and the signs also. And then they regress, but sometimes they aggravate, and then sometimes we have to deal with anticoagulation, but we do the normal one. In this case, we didn't, because we did not want to hemorrhage, to have hemorrhage on the field of the surgery.
One last question, Dr. Biscoito. What about, one of our colleagues is asking, what about covered stents for direct fistulas? That is something that we are not used to do in neuro, and I don't think you are probably using it, but I'd like to know if you are using covered stents for direct fistulas.
For direct fistulas.
Yes, for direct ones,
Yeah. Maybe for slow flow fistula, maybe a flow diverter, and it's done. But why put a flow diverter in a slow flow dural fistula if we can go by venous, and we don't let the patient double anti-aggregation with a stent inside the artery? Sometimes they are old patients that, well, we can do it, but it's more expensive. But we can of course do it for direct fistula. Yes, it is a possibility to, if it can be navigate the covered stent. Usually where we go by, before it was balloon approach. Now we don't use balloons. Of course, we use coils. Usually on direct fistula, if we can, we go by the arterial part with a balloon to protect the carotid, and to see where is the hole, and try with inflating the balloon like a hyperglide, for instance, try, and then go by venous side at the same time and start to put in coils, but protecting the carotid when we want to save the carotid. Of course, it can be done with not the balloon but the stent. But the problem is if we put a stent, a regular stent, and we don't inflate the balloon inside, the coil files can pass through the stent and go inside the carotid, and we don't see anything. When there are the big fistula, we don't see anything. So when if we inflate the balloon, it's more more safe, or at least we are more used to. But of course, there are different ways to. The important is to try to save the carotid if it is, of course, if it is possible.
Okay. Regarding follow-up, 3 months follow-up for these fistulas?
Oh well, if the clinically it's okay, it can be done 6 months, or if it's
Usually.
If we have any doubt of that it can something happen from, for instance, drainage to cortical veins, because we have to be aware, because we treat the fistula, the symptoms of the ophthalmologic part went away, but we can create, if it's not all closed, we can create what we call the white fistula, that is a dural cavernous sinus fistula, that the eye there is nothing in the eye, it's white, it's normal, and we think that the fistula has gone, and finally the fistula is draining to cortical veins. So for instance, it can happen. So we should always control.
And be even more dangerous.
Yeah, and even more dangerous. Exactly. Then we transform in type 2B, classification.
Yeah, with cortical vein.
Yeah.
Thank you so much for your time and for your excellent presentation. It was really a pleasure. And if I may, I'd just like to say that next week we have Dr. Demetrius Lopez from the US, and he's going to talk about neurovascular life after COVID-19. What will change forever? So I think it's a very interesting topic for next week. So Dr. Luisa Biscoito, I'm inviting already you for being to be with us as well. And thank you so much, and see you next week then. Thank you.
Okay. Thank you. Thank you
Bye-bye.
very much for the invitation, and very welcome. Say hello to everybody. Thank you very much.
Yes. Thank you. Thank you. Bye-bye.
Thank you.